Welcome. This webinar is about how health departments can focus efforts to build health equity in their communities. It seems that every organization and every organization's website mentions that health equity is a core value. But what is health equity? And how can that core value be realized? How do public health departments focus work on health equity in their communities? Well, governmental public health departments are central to creating health equity, are in a prime position to advance health equity. They cannot, however, be effective by focusing only on public health services that they provide and work independently. They need to work with others to transform policies, systems, and structures that create health inequities. Well, there's no single universally accepted definition of health equity. And often the terms disparities and social determinants of health and health equity are used interchangeably, but they actually have their own specific meanings. A single definition of health equity is probably not needed if we have agreement on the primary concepts of health equity. We need consensus on the critical elements of the causes of inequities and how they may be addressed or ameliorated. Each organization can create their own working definition of health equity, a definition that fits where they are on the continuum of addressing and creating health equity. So let's look at a couple adopted definitions of health equity. The core concept of health equity is that there should be equal opportunities for everyone to be as healthy as they can be. And that concept is in every definition of health equity. CDC's definition emphasizes the need to focus on injustices and obstacles to achieving health. This definition recognizes that systems and policies have promoted generational inequities and injustices, and they must be changed. Health disparities is included as part of this definition. The Robert Wood Johnson Foundation's definition provides details about the obstacles to health equity and includes powerlessness, discrimination, poverty, and a lack of access to good education, housing, fair pay, safe environments, and health care. Well, these are all important causes of health inequities. The definition adopted by ASTHO says that efforts should be made to address avoidable inequities and historical and current injustices, and to limit disparities. The concept that inequities are avoidable and are both historical and current is very important. As noted, every definition states that health equity is about everyone having a fair and just opportunity to attain their highest level of health. Key to achieving health equity is the removal of generational, structural, and systemic obstacles to fair and just opportunities. And obstacles include poverty, discrimination, powerlessness, and a lack of access to resources. Removal of those obstacles requires changes in the systems and the policies that have created and perpetuated the obstacles. These factors all create disparities in the health status of groups of people. Disparities of health are a way that we can measure the outcomes or results of a lack of health equity. They are the difference in the incidence, prevalence, and mortality of the disease and the related adverse health conditions that exist among specific populations. So disparities provide the evidence of the impact of health inequities. For example, Black and Hispanic populations are more likely to have asthma. Being exposed to mold or dampness, some allergens such as dust mites, and secondhand tobacco smoke has been linked to developing asthma. Air pollution and viral lung infection may also lead to asthma, and these are environmental health inequities. Focusing on such disparities with better, broader, more accessible public health services will address the result of the health inequities, but it will not address the causes. Public health must engage in efforts that address the social determinants of health that result in health disparities. Social determinants of health are those non-medical factors that impact on our health. They are the conditions and the environments in which we are born, live, learn, work, play, and age. They include the social, natural, built, and financial environments. These environments affect a wide range of health and quality of life, risks, and outcomes. The major drivers of health equity are the social determinants of health. For example, access to good education, social norms that reinforce healthful behaviors, discrimination, housing security, as well as safe housing. All of these contribute to health equity and inequity. This is a graphic that's used to explain health equity and how it differs from equality. And in this drawing, the shorter or smaller person has been provided a higher step up. This picture illustrates how inequities might be addressed by helping the individual or group. But wouldn't real health equity involve changing the built environment? That is, changing the structure and the system in place? So the bookshelf should simply be lowered so that everyone can reach the books. Then no individual or group will require special services, and everyone will have access. Building equity requires that we change historical and systemic structures so that everyone has equal opportunities and access to resources. Achieving health equity will require that we, as a society, rethink and change our structures, systems, and policies. Achieving health equity requires fundamental change. In this illustration, a different kind of offense would give everyone access. While health equity is a much larger issue than a single health department, all health departments can work to build equity in their communities. Health equity is felt at the community level where health departments work. Health departments can partner, collaborate, and coordinate with other community members to work together to have lasting impact on the social determinants of health. We will have achieved health equity when no one is prevented from being in good health because of social, economic, or other structurally determined circumstances. In other words, we will have achieved health equity as an outcome when a person's identity no longer exposes them to risks or grants them privileges. We will have achieved health equity as a process when those most affected by structural biases or injustices are fully and meaningfully engaged in the solutions to health inequities and the creation of health equity. To be effective, health departments need to act on the causes of health inequities rather than only the consequences of them. And the causes include the distribution of wealth, the provision of opportunities and privileges within a society that are provided to some groups and not others. Health departments need to build and broaden partnerships with a variety of community sectors and community members to share information and collaborate to advance health equity in the communities. Now, these are huge challenges, but they are core to building communities where populations can be healthy. Achieving health equity requires that health departments intentionally and strategically incorporate health equity as a vision and a mission throughout the department and engage in community health equity building activities. Health departments can begin by making health equity a strategic priority and building an internal infrastructure to support health equity development. Now, this requires more than a statement on a web page. It requires policies, education and training, and rethinking how things are done. Then health departments must partner with community members and work to address multiple social determinants of health. They must work to purposefully address structural powerlessness, bias, and injustices towards the elimination of racism and other forms of oppression. What can health departments do to combat health inequities and build health equity? Well, a study found that health departments tend to view their health equity work in three categories of efforts. A health department that defines their role in a functional way sees their primary role as collecting and analyzing data and then targeting resources and health department programs towards the priority populations identified in the data. Social determinants are viewed as risk factors that impact on an individual's ability to respond to health hazards. The focus then is addressing the outcomes of health inequities through the provision of individual services or programs. Now, a health department that defines its roles in terms of equality of opportunity offers targeted services to marginalized populations that are at higher risk for poor health outcomes. Health departments focus on these communities to provide equal opportunities for health. Collaboration and cross-sector work focuses on improving and increasing access to public health services and healthcare for those who need them most. A structural view focuses on collaboration and community-driven initiatives and grassroots efforts to encourage the community's engagement and strengthen community voices and actions. The focus is on generating health and well-being where people live, work, learn, and play, impacting on poverty, structural racism, patriarchal institutions, and oppressions are at the center of these efforts. While any one of these three views may be adopted as the overriding focus of a health department, they don't seem to be mutually exclusive. Each view's activities could reinforce the others. A health department may begin to address health equity in a functional way and then expand to take on all three levels of efforts. What health department capacities are needed to effectively take on health equity work? Well, first, a shared language and understanding of the root causes of inequity is needed. Based on that understanding, a shared commitment to allocating time and resources to disrupt systemic inequality is needed. Second, a formalized written commitment to health equity should be adopted in strategy and policy documents. Third, of course, strong leadership is needed to communicate and gain commitments for health equity. Systems for recruiting, hiring, and retaining diverse staff are a fourth capacity. The fifth capacity, of course, staff with skills and competencies necessary to advance health equity in their work. But this is about ongoing training. And finally, internal policies, processes, and decision-making structures that reinforce health equity work are needed. These are capacities that take time and dedication to develop and maintain. Health departments may want to begin their work by conducting a self-assessment of the department's capacity. Health equity capacity assessments can also be used along the way to assess progress. The Center for Health Equity at the Michigan Public Health Institute has a dialogue-based assessment instrument for health departments. It addresses the core elements of workforce, leadership, the community, and systems change. Another assessment tool is Race Matters Organizational Self-Assessment. It was developed by the Annie E. Casey Foundation in 2006. Well, yes, it was developed a long time ago, but it addresses staff competencies and organizational operations and can be useful. The results will classify the health department in one of four ways that will help the health department know where to start or to adjust its health equity work. The categories are become intentional, build staff and organizational capacity, fine-tune staff and organizational capacity, or mentor others. Human Impact Partners has created a practice-based framework that looks at health equity building activities in two categories, inside and outside. Now, inside activities are actions taken inside the health department to build the infrastructure and capacity needed to address health equity. They include activities such as staff training, data systems, policies, and budget allocation. Outside activities include building community partnerships, community initiatives, and grassroots approaches. As with all of public health, these efforts require that many people and organizations work together. Outside activities for health equity require challenging the status quo, the power bases, and the institutionalized structures. Partnerships that can create transformational alliances, new narratives, and channels for community voices are needed. Health equity practice requires well-established relationships based on mutual trust and shared leadership that can foster outside activities and strategies to advance equity over time. Inside and outside activities can be concurrent They can support each other. They're nonlinear. Well, let's discuss the inside and outside activities work a little bit more. Inside work builds the department's infrastructure for health equity work. Well, first, health departments will need to revisit their vision and mission statements and their strategic plans to ensure that seeking health equity is emphasized in an intentional and central way. Health equity work is not an afterthought or a single program or something that is appended to what you already do. Rather, it is core to public health work. Now, second, the adoption of a department health equity policy communicates intention. Policies may address processes for program development, community partnerships, organizational leadership, the department culture, human resources, and program evaluation. Health equity can be built into hiring processes, as well as ongoing staff development and training. Now, budgets are policy documents, so it's important that health equity is seen as a core decision point or criteria for budget decisions. And health departments can build health equity expectations into their human resources infrastructure. They can, for example, require that each staff person has at least one annual goal that specifically addresses health equity, and that health equity work becomes part of the employee's annual evaluation. Department-wide principles that could be adopted in a department policy statement could include that the department will be explicit and intentional about addressing the causes of inequities, always use a health equity lens in setting policies and developing programs and interventions and budgets, always encourage community voices and partner with community members, work to strengthen community capacity so that the community is resilient and effective. Make sure that communications and services are always provided in a culturally and linguistically appropriate way. Question historical institutions and practices that may promote inequities. An adopted department policy that states these principles can provide guidance, set expectations, and hold staff accountable. The structure of a department policy would be more than just a simple paragraph stating support of health equity. An adopted health department-wide policy statement would set expectations and provide guidance to staff. An overarching statement could explicitly express the intent to eliminate all forms of structural health inequities. A department-wide policy should include definitions of terms to provide a common language. And it's important to set expectations for leadership and describe the organizational culture that the department is working to create. For example, the policy might state that the department supports a culture of learning or an expectation of engagement with the community. A statement could say that when a policy is developed or revised, the department will consider the positive and the negative impacts on equity and who will benefit and who will be burdened by a particular policy. And the involvement of those affected by the policy could be required. An expectation that program and staff build relationships with their community and community members could be stated. Engagement with communities can ensure that community members make decisions and shape their own communities. It can help to build community capacity and resilience. And it's critical that departments' communications practice cultural humility and respect. This means that the department must communicate with sensitivity and awareness. Program evaluations can assess unintended consequences, positive or negative, of a particular policy, program, or intervention. They can include an assessment of changes in community members' lived experiences to ensure that efforts are appropriate for the community. And finally, human resources policies concerning hiring, retention, and staff evaluations should work to establish a department that operationalizes the intent to change historic and current structural causes of health inequities. Outside health equity is about listening to the community and building relationships. Health equity work cannot be a project. It's not an effort that the health department designs and then invites the community to participate. Relationships take time and effort, and they require that trust be developed. What is the community that the health department must work with? It is those who face inequalities, discrimination, and bias. Departments must engage with the community to work with them on the community's priorities. The health department can play a convening role, but not necessarily a leadership role. Health departments have resources to offer. Health department resources include maybe meeting rooms, data, ways to communicate with the community, for example, social media. The health department can identify and mentor community leaders. Health departments may have access to decision makers and those who set policies. This builds the community capacity. The objective is to develop the community members' capacity to know how and when to act. Now, some community leaders and officials may not be open to the health department using its resources to address health inequity. To some, it makes more sense for health departments to simply provide services. For example, dental clinics, STD treatments, and restaurant inspections. Skepticism about wokeness may make the term health equity disliked by some. So the health department may need to use different terms and language to describe its work when it requests local or state funding, develops activity reports, or talks with the media. Well, FAB, the Public Health Accreditation Board, uses the phrase populations at greater risk for poorer health outcomes, but you can come up with your own language that's appropriate for your community. Some health departments are seeking initial or reaccreditation from the Public Health Accreditation Board, FAB. The accreditation standards and measures, version 2022, include 2 measures specific to health equity. So let's look at what accreditation expects from the health department. FAB has adopted standards and measures that health departments must demonstrate to be accredited. Now, the first measure to address health equity specifically is measure 5.2. This measure assesses the health department's intentional approach to address health inequities and differences in health outcomes. It requires that there is documentation of a policy or procedure that demonstrates how health equity is incorporated into processes, programs, or interventions. The measure also requires that there be documentation of implementation of a strategy to address health equity. The implementation must involve stakeholders, partners, or the community. These strategies may address, for example, social change, policy, services, health communication, the level of community resilience, or the community environment. The other FAB measure that explicitly addresses health equity is measure 10.2.1. So the purpose of this measure is to assess the health department's process for reviewing, revising, and sharing health department policies and programs with staff. But the measure also specifically requires a health department-wide policy or initiative that addresses inclusion, diversity, equity, and anti-racism principles. The measure requires that the department has adopted a set of defined health equity related terms. The terms are meant to establish an understanding among staff and also set the context for department-wide health equity work. This measure also requires that the department have a written policy, a declaration, or an initiative that demonstrates how inclusion, diversity, equity, and anti-racism concepts are integrated throughout the department. Health departments that are interested in public health department accreditation will want to keep these requirements in mind. Health equity work is community-specific work, driven by the lived experiences and priorities of community members. Health equity initiatives are derived from the partnerships and collaborations that a health department builds with its communities. They build on community assets to increase community capacity and efficacy. There are, however, a good deal of health equity related resources available. Discussions, plans, and tools are currently accessible. For example, the National Association of County and City Health Officials, NACCHO, provides an online health equity course for public health workforce. The Association of State and Territorial Health Officials, ASTHO, has a health equity policy toolkit available on their website. Health Impact Partners website includes a health equity guide, and the Network of Public Health Laws website provides a tool for the equity assessment of laws and policies. The internet searches no doubt will identify more tools, and new guidelines, tools, process, and templates are being developed every day. That means that health departments need to grow a culture of continuous learning and a never-ending commitment to addressing the systems, policies, structures, and procedures that perpetuate barriers to health equity. Building a world where everyone has a fair and just opportunity to attain their highest level of health is a forever challenge. Health equity is core to the public health's mission, value, and responsibility. It's a way of life. Thank you for your interest and for your commitment to work towards creating health equity in your communities.